Welcome. NSG 419. Study Section 6. Other conditions affecting newborn. Introduction. In this section, you will take a look at other conditions that affect newborns. Respiratory problems, asphyxia, neonatorium, and respiratory distress syndrome. In neonates, low birth weight babies, jaundice, and neonatal infections. Learning outcomes. When you have studied this section, you should be able to 1. Point out the management procedure of specific respiratory problems. 2. Assess and classify the sick young infants. 3. Check for a feeding problem or low weight. Assess breastfeeding and classify feeding. 4. Teach the mother to treat local infections at home. 5. Teach correct positioning and attachment for breastfeeding. 6. Advise the mother how to give home care for the young infants. Respiratory problems, asphyxia, neonatorium, and respiratory distress syndrome. Asphyxia neonatorium. Definition. Asphyxia neonatorium is a respiratory failure in the newborn, a condition caused by the inadequate intake of oxygen before, during, or just after birth. Description. Asphyxia neonatorium, also called birth or newborn asphyxia, is defined as a failure to start regular respiration within a minute of birth. Asphyxia neonatorium is a neonatal emergency as it may lead to apoxia, lowering of oxygen supply to the brain and tissues, and possible brain damage or death if not correctly managed. Newborn infants normally start to breathe without assistance and usually cry after delivery. By 1 minute after birth, most infants are breathing well. If an infant fails to establish sustained respiratory after birth, the infant is diagnosed with asphyxia neonatorium. Normal infants have good muscle tone at birth and move their arms and legs actively, while asphyxia neonatorium infants are completely limp and do not move at all. If not correctly managed, asphyxia neonatorium will lead to apoxia and possible brain damage or death. Causes. There are many causes of asphyxia neonatorium, the most common of which include the following: prenatal apoxia, a condition resulting from a reduction of the oxygen supply to tissue below physiological levels despite adequate perfusion of the tissue by blood. Umbilical cord compression during childbirth. Occurrence of a preterm or difficult delivery, and maternal anesthesia. Both the intravenous drugs and the anesthetic gases cross the placenta and may sedate the fetus. Mothers with previous abortions, stillbirths, early neonatal deaths, or preterm births. Lack of prenatal care. Abnormal fetal presentation or position. Alcohol abuse and smoking by the mother. Severe fetal growth retardation. Preterm labor. The symptoms. The symptoms of asphyxia neonatorium are bluish or gray skin color, cyanosis, slow heartbeat, bradycardia, stiff or limp limbs, hypotonia, and a poor response to stimulation. Notes: pregnant women who are at high risk of delivering newborns with asphyxia neonatorium should arrange for a close follow-up of their pregnancy with their obstetrician. Diagnosis. Diagnosis can be objectively assessed using the APGAR score, a recording of the physical health of a newborn infant, determined after examination of the adequacy of respiration, heart action, muscle tone, skin color, and reflexes. Normally, the APGAR score is of 7 to 10. Infants with a score between 4 and 6 have moderate depression of their vital signs, while infants with a score of 0 to 3 have severely depressed vital signs and are at great risk of dying unless actively resuscitated. Management. The treatment for asphyxia neonatorium is resuscitation of the newborn. All medical delivery rooms have adequate resuscitation equipment should an infant not breathe well at delivery. Between 1970 and 2000, neonatal resuscitation has evolved from desperate stitching methods to organized programs. The most widely used procedures is the neonatal resuscitation program, supported by the American Academy of Pediatrics (AAP) and the American Heart Association (AHA). If stimulation fails to initiate regular respiration in the newborn, the attending midwife attempts resuscitation. He may decide first to gently suction the oropharynx, the area of the throat at the back of the mouth, with a soft catheter. When stimulation and a clear airway do not result in adequate respiration, the physician may give 100% oxygen via a face mask. If the infant is still not breathing, some form of artificial ventilation is then required. The usual method is to use mask ventilation with resuscitator. The mask is applied tightly to the infant's face. If the infant does not breathe despite adequate ventilation, or if the heart rate remains below 80 beats per minute, the physician can give an external cardiac massage using 2 fingers to depress the lower sternum at approximately 100 times a minute, while continuing with respiratory assistance. Adrenaline may also be administered to increase cardiac output. Once the infant starts breathing, he or she is transferred to a nursery for observation and further assessment. Temperature, pulse and respiratory rates, color and activity are recorded, and blood glucose levels checked for at least 4 hours. Treatment may also include the following: giving the mother extra amount of oxygen before delivery, medications to support the baby's breathing and sustain blood pressure, extracorporeal membrane oxygenation (ECMO). ECMO is a technique similar to a heart-lung bypass machine, which assists the infant's heart and lung function with use of an external pump and oxygenator. Alternative treatments: if an inadequate supply of oxygen from the placenta is detected during labor, the infant is at high risk for asphyxia, and an emergency delivery may be attempted either using forceps or by cesarean section. Prognosis. The prognosis for asphyxia neonatorum depends on how long the newborn is unable to breathe. For example, clinical studies shows that the outcome of babies with low 5 minutes APGAR scores is significantly better than those with the same scores at 10 minutes. With prolonged asphyxia, brain, heart, kidney and lung damage can result, and also death if the asphyxiation lasts longer than 10 minutes. Respiratory distress syndrome. Description: respiratory disorder that involves widespread alveolar collapse is the most common cause of neonatal death. If mild, it subsides slowly after about 3 days. It affects neonates born before the 27th gestational week and occurs in about 60% of those born before 28th week. It is most common in neonates of mother with diabetes, neonates delivered by cesarean birth, and neonates delivered suddenly after antepartum hemorrhage. Certain complications are associated specifically with the preterm neonate. Also, it is called hyaline membrane disease. Causes: surfactant deficiency stemming from preterm birth. Signs and symptoms: history of preterm birth or cesarean births, maternal history of diabetes or antepartum hemorrhage, rapid, shallow respirations, intercostal, subcostal or sternal retractions, nasal flaring. Management. Anticipate that condition requires aggressive management assisted by mechanical ventilation with positive end expiratory pressure (PEEP) or continuous positive airway pressure (CPAP), administered by a tight-fitting face mask or, when necessary, an endotracheal tube. For a neonate who can maintain adequate gas exchange, provide high-frequency oscillation ventilation. Put the neonate in a radiant warmer or an isolate. Provide warm, humidified, oxygen-enriched gases via oxygen hood or mechanical ventilation. Provide tube feedings or total parenteral nutrition. Administer IV fluids and sodium bicarbonate, pancuronium, bromide, prophylactic antibiotics, diuretics, surfactants, replacement therapy, vitamin E and antenatal corticosteroids as ordered. Anticipate that a trichostomy may be necessary. Monitor vital signs closely. Assess skin color and integrity. Report signs of decreased peripheral circulation. Monitor pulse oximetry. Measure daily weight and monitor intake and output. Check the umbilical catheter for arterial or venous hypotension as appropriate. Suction as necessary. Adjust PEEP or CPAP settings as indicated by anterior blood gas values. In a neonate or mechanical ventilator, watch carefully for signs of barotrauma and accidental disconnection from the ventilator. Check ventilator settings frequently. Be alert for signs of complications of PEEP or CPAP therapy, such as decreased cardiac output, pneumothorax and pneumomediastinum. Avoid garbage and oral feedings during the acute stage of the disease. Cluster nursing activities to provide the neonates with rest periods. Implement measures to prevent infections. Provide skin and mouth care every 2 hours. Encourage patients to participate in the neonates care. Offer emotional support. 8 low birth weight babies. Small for gestational age neonates. Definition. This is defined as birth weight at or below the 10th percentile or intrauterine growth chart. It occurs in premature, full-term, or post-mature neonates. Causes: maternal contribution factors, poor nutrition, advanced diabetes, gestational hypertension, smoking, age older than 35, drug use, partial placenta separation and malfunction. Fetal contribution factors: intrauterine infection, chromosomal abnormalities and malformations. Signs and symptoms: wide-eyed look, sucking abdomen, loose, dry skin, decreased chest and abdomen circumferences, decreased subcutaneous fats, thin, dry umbilical cord, sparse cap air. Management: support respiratory efforts, monitor respiratory status closely for changes, institute respiratory care measures as indicated by the neonate's condition, provide a neutral thermal environment, institute measures to protect the neonates from infection, provide appropriate nutrition, administer IV fluids. Notes: monitor body glucose levels. Hypoglycemia is common due to reduced glycogen stores. IV glucose may be needed if blood glucose levels are lesser than 40 mg per dl. Maintain adequate hydration. Monitor intake and output. Cluster nursing care activities to minimize the neonate's energy expenditures. Provide meticulous skin care. Provide a neutral thermal environment. Institute measures to protect the neonate from infection. Provide appropriate nutrition. Administer IV fluids. Preterm neonates. Description. This is described as the delivery of a neonate before the end of 37 weeks gestation. It is associated with numerous problems caused by immature body systems. Extent of immaturity depends on gestational age and level of development at delivery. Best chance of survival in preterm neonates between 28 and 37 weeks gestation. Causes. Underlying conditions that result in the delivery of the neonates before term, associated with maternal risk factors: multiple pregnancy, adolescent pregnancy, lack of prenatal care, substance abuse, previous preterm delivery, high unexplained alpha fetoprotein level in second trimester, uterine abnormalities, cervical insufficiency, premature rupture of membranes, placenta previa, gestational hypertension. Veins clearly visible under the thin, transparent epidermis. Lanugo hair over the body. Sparse, fine, fuzzy hair on the head. Soft, palpable hair cartilage. The hair may fold easily. Minimal creases in the soles and palms. Prominent eyes, possibly closed. Few scrotal ruga, males. Under-descended testes, males. Prominent labia and clitoris, females. Inactivity, although may be usually active immediately after birth. Extensions of extremities. Absence of suck reflex. Weak swallow, gag and cough reflexes. Weak grasp reflex. Ability to bring the neonate's elbow across the chest when eliciting the scarf sign. Ability to bring the neonate's heels to his ear easily. Management. Perform cardiac and respiratory assessments and provide assistance. Perform resuscitation, endotracheal intubation, and mechanical ventilation if necessary. Monitor and maintain fluid and electrolyte balance. Provide nutritional support. Institute measures to protect the neonate from infection. Assess neurologic status. Maintain body temperature and neutral thermal environment. Anticipate the need for an incubator or a radiant warmer. Monitor renal function. Provide emotional support to parents. Assess glucose and bilirubin levels. Closely assess all body systems. Administer oxygen, avoiding concentrations that are too high. Notes: neonates born before 32 weeks gestation have uncoordinated sucking and swallow reflexes. Therefore, gavage or IV feeding may be necessary. Provide non-nutritive sucking via a pacifier as appropriate. Complications that may affect preterm neonates. Because of the preterm neonates, fragile condition and the numerous treatments and procedures typically needed, these complications commonly occur to respiratory distress syndrome, intraventricular hemorrhage, retinopathy of maturity, patent ductus anteriosus, necrotizing enterocolitis, bronchopulmonary dysplasia, apnea of prematurity. Jaundice. Jaundice is a yellowing of the skin and or white of the eyes caused by high levels of bilirubin, a dark yellow green or orange-red pigment in the blood. Jaundice, also called Asterios or hyperbilirubinemia is a very common condition in newborns. Newborn or neonatal jaundice, sometimes referred to as physiologic or physiological jaundice, affects more than half of all full-term newborns and 80% of premature newborns within the first few days of life. It commonly lasts for 1 to 2 weeks. Jaundice that is present at birth or that lasts more than a couple of weeks may be abnormal jaundice and the symptoms of an underlying problem. Jaundice in older children or adults is a symptom of hepatitis, inflammation of the liver, or some other liver disorder. Jaundice results from higher than normal levels of bilirubin in the blood. Bilirubin is a breakdown product of red blood cells. Red blood cells normally are removed and broken down in the spleen after about 120 days in circulation. M. Component of hemoglobin in red blood cells that carries oxygen throughout the body is broken down into bilirubin, which moves to the liver where it is processed and added to a bile, a digestive fluid. The bile travels through the bile duct to the intestine and is excreted in the stool. Infants are born with excess red blood cells that are rapidly recycled by the spleen and liver, releasing bilirubin. This pigment gives a newborn stools their yellow color. If more bilirubin is produced, that can be processed by the liver, blood levels of bilirubin rise and the excess is deposited in tissue, causing the skin to appear yellow. This condition occurs in about 1 in every 15,000 live births, and girls are slightly more at risk than boys. Neonatal jaundice. Description. Prior to birth, the mother's liver processes bilirubin for the fetus. At birth, particularly with preterm birth, an infant's immature liver may not be able to process all the bilirubin formed as red blood cells are removed from circulation. The excess bilirubin causes jaundice by the 3rd or 4th day after birth. The jaundice usually appears first on the face and progressive towards the chest, abdomen, legs, and feet. If newborn feeding is delayed for any reason, such as illness, a digestive tract problem, or low fluid intake due to inefficient breastfeeding, the infant produces fewer stools, resulting in critically high blood levels of bilirubin and severe jaundice. Most full-term babies with neonatal jaundice have no other symptoms. However, if bilirubin levels continue to rise, other symptoms may include sleepiness, lethargy, slow or reluctant feeding. Risk factors for hyperbilirubinemia include birth more than 2 weeks before the due date, jaundice within the first 24 hours after birth, significant bruising or bleeding under the scalp caused by labor and delivery, high bilirubin levels prior to hospital discharge, difficulty breastfeeding resulting in low fluid intake, a parent or sibling who had high bilirubin levels at birth. Pathological jaundice in newborns. Jaundice at birth or within the first 24 hours after birth can be a sign of pathological jaundice. Pathological jaundice can be dangerous, particularly in preterm or unhealthy newborns, depending on the cause and extent of the jaundice. It also may be harmful in full-term infants. The most common cause of pathological jaundice is an ABO blood type incompatibility between mother and child. If the mother has O negative type blood and the infant has either A or B blood type, or if the mother has A type blood and the child has B type or vice versa, the mother's antibodies circulating in the baby's blood attack the child's foreign blood type, causing damage to and destruction of the baby's red blood cells. This process called hemolysis is accompanied by the release of excess amounts of bilirubin. Diagnosis. Newborns are examined under a good light for signs of jaundice. A simple blood test with a few drops of blood taken from the infant's ears measured bilirubin levels in the blood. The test may be repeated frequently in the jaundiced newborn to assure that bilirubin levels are dropping. An instrument called a bilirubinometer can be held against the baby's skin to assess the level of jaundice. The Minotaur or Ilrom air shields. Transcutaneous jaundice meter accurately measures bilirubin levels by shining light of different colors through the skin and measuring the reflection, eliminating the need for blood tests via ear pricks. If there is a reason to believe that the newborn is suffering from an pathological jaundice, additional tests may be performed. These include blood cell counts to detect anemia, tests for blood clotting function, tests for excess destruction of red blood cells, blood tests to assess liver function, a liver biopsy, in which liver cells are removed and examined under a microscope to look for liver disease, urine and stool sample to check for signs of bacteria or viral infection. Ultrasound scanning, which uses sound wave to obtain images of the liver, gallbladder, and biliary tracts. Abdominal ultrasound can distinguish between jaundice caused by biliary atresia and jaundice caused by liver malfunction. Magnetic resonance imaging, MRI of the liver. Computed tomography, CT, or computed axial tomography, CAT scans, which use a thin rotating X-ray beam to obtain an image. Endoscopic retrograde cholangiopancreatography, ERCP, in which a radiopaque dye that is visible on X-ray is inserted into the upper portion of the small intestine so that it flows back up the biliary tracts. Liver scans using radioactive dyes. Management. Neonatal jaundice usually requires only observation. The infant may stay in the hospital for an extra day or return within the next few days for an examination. However, jaundice in a preterm baby may require intensive care. As the infant's liver matures and the excess blood cells are removed, the jaundice disappears. The child may be given additional fluids, possibly intravenously, to help remove the bilirubin. Frequent feedings leads to more frequent stools, which reduces the reabsorption of bilirubin from the intestines into the blood. Breast milk usually is considered superior to water or formula for relieving jaundice because breast milk produces stools with every feeding, thereby excreting bilirubin. Breastfeeding should not be discontinued because of neonatal jaundice. An eye sheet protects the baby's eyes. The infant is removed from the incubator for feeding. Other phototherapy methods such as fiber optic bilirubin blankets incorporate the light into a blanket so that the child can be breastfed during treatment or treated at home. Phototherapy is continued until bilirubin levels have returned to normal, usually within a few days. Side effects of phototherapy may include loose stools, rash, dehydration, sleepiness, disinterest in breastfeeding. If bilirubin approaches a dangerous level, a next-stage blood transfusion is used to rapidly lower it. A catheter is placed into the umbilical vein at the cut surface of the umbilical cord. The newborn's blood is replaced with an equal volume of newborn blood. RH incompatibility also may be treated by exchange transfusion. Antibiotics may be used to prevent or treat a suspected infection in jaundiced infants. Babies with very severe jaundice have their hearing tested and are monitored for several months. Surgery for biliary atresia must be performed within the first few weeks of an infant's life to prevent further liver damage. About 40 to 50% of infants with biliary atresia are candidates for replacement bile ducts leading from the liver into the intestine, called the CASA procedure or hepatocolon potoenterostomy. The obstructed ducts are replaced with sections from the infant's intestines. Infants with duct obstruction within the liver itself usually require a liver transplant by the age of 2. Prognosis. Neonatal jaundice disappears after 1 to 2 weeks. It may last slightly longer in breastfed infants. The jaundice does not harm the infant in any way, and breastfeeding should not be discontinued. Severe untreated jaundice leading to Kennisetterios may result in the following: mental retardation, cerebral palsy, deafness, death. Untreated biliary atresia leads to biliary psychosis, a progressive irreversible scarring of the liver. By about 2 months of age, about 50% of bile duct replacement surgeries are successful, and jaundice usually disappears within several weeks. Despite this success, the liver damage often progresses on to cirrhosis. Breast milk jaundice resulting from a reaction to a breast milk component is not dangerous. The baby's liver soon adapts to the problem and the jaundice disappears. Neonatal infections. Neonatal sepsis. Description: it occurs when pathogenic microorganisms or their toxins occur in the blood or tissues. It may occur before, during, or after delivery. Causes: any bacteria, virus, or fungus. Most commonly, gram-negative Escherichia coli, Aerobacter and Klebsiella, and gram-positive beta hemolytic streptococci. Prolonged rupture of membranes increasing the neonate risk of sepsis. Signs and symptoms: subtle non-specific behavioral changes such as lethargy and hypotonia, temperature instability, feeding pattern changes such as poor sucking and decreased intake, apnea, hyperbilirubinemia,